All right, welcome to another episode. Today we're going to talk about potassium. Potassium is cool. All right, it can mess with a lot of things like your heart, so it's pretty important. So let's get right into it. Number one thing I want you to know is that potassium is necessary for muscle contraction, all muscle contraction. This means smooth muscle and heart muscle and skeletal muscle are the most affected by this, right? So patients who have low potassium will come in complaining of weakness. Their muscles cannot contract. In addition, it affects the heart and can cause arrhythmias and all kinds of problems, AV blocks, etc. So that's the first thing to know is that potassium is needed for muscle contraction. Also, another thing to know is that anything that affects the sodium potassium ATPase can potentially affect the potassium level. So things that stimulate the ATPase, like epinephrine or insulin or digoxin, um, can, digoxin actually inhibits the sodium potassium ATPase. Anyways, this can cause an increase in the inter or intracellular potassium concentrations and cause a low serum potassium concentration. So let me say that again. So anything that stimulates the sodium potassium ATPase can cause hypokalemia. Anything that can slow or inhibit the sodium potassium ATPase causes hyperkalemia, right? Simple. Um, and the next thing to do when assessing a patient with low potassium is just ask yourself, is this worthy of investigation? A lot of patients come in, they have a little bit of low potassium, uh, you replete it, and it's fine, it stays. So I think there is definitely a threshold that is worthy of investigation. And so let's just get right into this schema here. So, why did I put a picture of Donald Trump in this schema? Well, it helps me remember what the causes of hypokalemia are. So just focus on that first portion of the word rigged, um, and remember rig. And of course, the I is for intercellular shifts. All right, so R, I, and G. Rigged. Good picmonic right there. Okay, so let's get into this. So I am going to write out kind of the steps of what to do um, when assessing hypokalemia that's worthy of further investigation. So, as I mentioned before, you always want to rule out GI and diuretic causes because these are by and away the most common, whether it be nausea, vomiting, diarrhea, or just chronic diuretic use. Those typically give you the answer. So that's kind of my first approach is we'll do HPI, um, HPI medications, and ruling out GI losses. All right, I don't like that one. All right. By and away, that this step right here will give you your answer. All right. If it does not give you the answer, then next thing you can do is check the pH. Why check the pH? Well, um, the pH can help clue you in whether or not that this is uh, in this category over here or this category over here. So if you're dealing with something it's rare, but it happens, like a renal tubular acidosis, um, or more commonly, patients dehydrated and has contraction alkalosis, but that can really help clue you in. And of course, if the patient's unresponsive or unable to give a history, then your pH can further help determine if this was due to vomiting or diarrhea. And I want to just summarize what I said here. Say this can come from the history, as well as reviewing medications, of course, diuretics, like we mentioned before. So you can usually get your answer there. Order labs. Maybe the mag is low. So usually you can get your answer there, but from the first two steps: thorough history, reviewing the medications, ruling out GI losses, and then checking the patient's pH. That can really help clue you in. If you're suspecting renal etiology, you can check the urine chloride. And so anytime a patient has hypovolemia, whether it be due to nausea, vomiting, diuretic use, whatever the reason may be, the patient's RAS system is ramped up, it's turned on because of the low effective circulating volume. This causes an increase in sodium and chloride reabsorption. So anytime the RAS is activated, you're going to have low urine chloride because RAS is activated and you're reabsorbing all of your salt. Okay. This also goes in line with saline responsive metabolic alkaloses. Saline responsive metabolic alkaloses, it's the same idea. The patient, for whatever reason, is hypovolemic. They have a low effective circulating volume. So this does respond to saline. So we can write that for number 4. And then that can definitely better help clue you in. And if you're suspecting one of the more rare conditions that can cause unresponsive metabolic alkalosis, like hyperaldosteronism, check the blood pressure of the patient, because that can help clue you in to know if this patient has inappropriate increased hyperaldosteronism. Okay. Now, I also wanted to mention that patients that have excess cortisol in their blood, they can have symptoms of hypertension as well as hypokalemia, and really similar symptoms to hyperaldosteronism. So the reason why this does not occur in normal patients is because there's an enzyme called 11-beta steroid dehydrogenase, I believe. That enzyme is responsible for breaking down cortisol into cortisone, and cortisone is not active in the aldosterone receptor. However, in states of excess cortisol, like in Cushing's, then this enzyme gets overwhelmed and causes activation of aldosterone receptor, and boom, hypertension, hypokalemia, just like that. All right. One step I actually wanted to put, I guess it should go right here, is asking yourself, is this problem located at the kidney? Is the kidney behaving appropriately? And again, you can get there by checking the pH, or it can help clue you in. But really, ask yourself if you suspect that this is worthy of investigation. Right after ruling out GI and diuretic losses, then so I would put that right here. So ask yourself, Um, is this problem at the kidney? Okay. All right. All right. Moving on. I also wanted to mention some other important things about potassium in general is that it's almost impossible to get hypokalemic from low dietary intake. I mean, it's possible with chronic alcoholism, patients don't eat, or in states like anorexia, but as little as a half of one banana a day can maintain your serum potassium because the body can slow its excretion of potassium to half a banana a day. One banana is 10 milliequivalents, and the kidney can slow potassium excretion to about 5 milliequivalents. So pretty cool. Another thing to know is that potassium regulation occurs strictly at the collecting duct, and it's determined by two things. So maybe I should write this down. I'll put K regulation. Occurs at two places. Excuse me, occurs at the collecting duct, but it occurs for two reasons. Okay. Number one is aldosterone, because aldosterone activates the ROMK channel and other things in the collecting duct, or flow rate. So things that increase your flow rate can increase potassium excretion. For example, diuretics. All right. So pretty cool and pretty helpful to understand the physiology of what's going on there. All right. So after you have clued in that this is your suspected renal pathology, check the pH. This can help differentiate between renal tubular acidosis or contraction alkaloses, or alkalosis caused by other things. If you do suspect that this is, are confirmed by pH that this is in fact a metabolic alkalosis, then you can give the patient saline, check the urinary chloride before, and then if it warrants further investigation, keep an eye on those blood pressures. Make sure the patient does not have an increase in serum aldosterone. And this should really help clue you in from there. What else? In terms of Barter's or Gittleman's, I just wanted to say that Gittleman's is more common. It's more mild and usually comes with low mag and low calcium in the serum. All right. And that is it. One last thing I wanted to say was that if the patient has metabolic alkalosis, just remember the mechanism behind the contraction alkalosis and why you get low urinary chloride. Again, because when RAS is activated, your body is not only absorbing the sodium, it's also reabsorbing the chloride, and this causes a low urinary chloride. All right, in summary, do a thorough history and medication review and rule out GI losses. Then you can ask yourself, is this problem at the kidney? Check a patient's pH, check the urinary chloride, give saline, and do some recurrent blood pressure checks. And this usually should clue you in on the answer.